All right. Well, thank you so much for that introduction, Pat. So I'm going to talk today about diagnosis and treatment of Lewy body dementias and frontotemporal dementias. Um, I'm a employee of the federal government. My opinions are not those of the federal government. They are my own, thank goodness. I have no major conflicts of interest relevant here. I do some CME related work and do some teaching and things like that that I get honoraria for, but nothing particularly relevant for this. We're going to talk about, oh, and this is incorrect. I used the wrong slide here. So this is great, but what I'm going to do is just change this to say treatments. I'm just going to remove this because we're going to talk about some common language, and then we're going to talk about Lewy body dementia and frontotemporal dementia, and we'll talk about diagnosis and treatment of both. Um, so prior to talking about specific causes of dementia, I think it's important to be on the same page with regards to terminology and language. So any diagnosis of a cognitive disorder, it's two pieces. It's always a description of the syndrome and then a description of what's causing that syndrome. So normal aging is what the changes that we expect to occur with aging. And bad news for anybody over the age of 25, there's a decline as we all age. So we are not the same people that we were, when we were 25. Our memory is changing, our executive functions are changing. And so it's not uncommon that I get people that come in and they say, my memory's not as good as it used to be. And that's important because that's almost always true. The real question isn't, is it what it used to be, but is it worse than it ought to be given age, education, and other demographic factors? When there is an objective decline in some type of cognitive function, memory, language, executive functions, etc., uh, and people are, but they're doing okay in their day-to-day functions, that's what we call mild cognitive impairment. Mild cognitive impairment can be a stage that precedes dementia in conditions, but it can also improve. So this might be, for instance, somebody who has sleep apnea who gets that treated, and maybe their cognitive impairment was secondary to their sleep apnea and fatigue. In some instances, the mild cognitive impairment seems to stay stable and not really get worse year after year. And then in some instances, it does progress to dementia. And dementia as a term just means that there's objective impairment in usually multiple cognitive domains, and there is impairment in someone's activities of daily living. Now, it starts with mild dementia, and that's where people have trouble with instrumental activities of daily living, like driving, cooking, cleaning, managing their finances. Then there's moderate dementia, and that's when people's basic activities of daily living are impacted, feeding oneself, dressing oneself, personal hygiene activities. Severe dementia is when someone is fully dependent on another for all of their personal care. This is often the stage where people can be bedbound and the like. So dementia is a very, very broad category. When we are talking about the causes of dementia, these are the most common ones, right? So Alzheimer's disease is a neurodegenerative disease that is the most common cause. If you consider all causes of dementia after that, vascular dementia is the next most common. And this includes anybody who's had a large stroke who has dementia secondary to that. And so, because vascular disease is so common, it makes sense that vascular disease is the second most common cause of dementia. Lewy body dementia is the second most common neurodegenerative cause of dementia. And then finally, frontotemporal dementia is a little less common than that, but is a more common finding in those before the age of 65 than it is after the age of 65. And there are a host of other less common causes, but these represent sort of the four big ones that we talk about. And we're going to focus on these today: Lewy body dementias and frontotemporal dementias. So when we talk about Lewy body dementias, this is the terminology here is really complicated. I'm going to give you the way I am using the terminology and the way that experts in the field use the terminology. I will tell you that many neurologists are not going to be this precise with their language, and I'll try to point out where some of those imprecisions are that I see. Um, so Lewy body disease can lead to Parkinson's disease and Lewy body dementia. But Lewy body dementia is really not a precise diagnosis. It's a combination of two more specific diagnoses, and that's Parkinson's disease dementia and dementia with Lewy bodies. It's not uncommon for people in the community to use Lewy body dementia and dementia with Lewy bodies interchangeably. Um, and it is it's not wrong because dementia with Lewy bodies is a type of Lewy body dementia, but it's just not quite as precise. And I'll describe why. So, Parkinson's disease, when people have well established Parkinson's disease for at least a year, and then they go on to develop a dementia syndrome that has the characteristics of Lewy body dementias, we call that Parkinson's disease dementia. Um, if they develop the dementia within a year or preceding the motor symptoms of Parkinson's disease, we call that dementia with Lewy bodies. They share a lot of features. They share the same pathology, they share the same set of symptoms, and they share many of the same cognitive and behavioral features. Uh, in reality, I'm giving this to you like there are these two discrete categories, like you're always going to be able to differentiate the two. In reality, there is a spectrum of disease so some people look a lot more like dementia with Lewy bodies, and then some people look a lot more like Parkinson's disease dementia. But there are plenty of people sort of that span the spectrum between the two. And so it's not always possible to clearly say which one it is. So when I use the term Lewy body dementia, I'm being intentionally a little bit vague because what I'm trying to indicate is that it's one of these two, and it really doesn't matter for the treatment planning which it is. And so rather than waste time trying to be overly precise, I'll just say a Lewy body dementia and then describe the symptoms that we are focused on. The shared set of symptoms are hallucinations, Parkinsonism, REM sleep behavior disorder, which is acting out dreams, and then these large fluctuations in attention or wakefulness that will happen. Now, the most frequently cited, well-known case of DLB was Robin Williams. His wife has written a very nice op-ed and has written widely about the experience of watching Robin's change later in life. A lot of people blamed it on, when he was experiencing the symptoms, people kind of blamed it on his history of bipolar disorder. But of course, visual hallucinations are not common out of the blue with people who've had stable bipolar disorder for years. And she would describe, he would go from lucid with clear reasoning 1 minute to 5 minutes later, just blank and lost in confusion. And he would just describe this feeling of wanting to reboot his brain. These are very common descriptions in Lewy body dementias. And often people will talk about good days and bad days with dementias, and that's true of any dementia. Lewy body dementia, there are often good hours and bad hours. So the fluctuations tend to be more frequent and more present throughout the course of a day. So a big question that comes up a lot is, can symptoms look like Lewy body dementia? and not be. So, for instance, can people present with a dementia syndrome that has early visual hallucinations and delusions, and maybe even some Parkinsonism, and maybe it's not Lewy body dementia? And the answer is yes. So, the the clinical syndrome that we describe for Lewy body dementia, you can see it in other instances. And so I've had some people come to me and they've been just adamant, like, I have Lewy body disease. I heard the talk. It sounds like Lewy body disease. I must have Lewy body disease. And then after a thorough evaluation, more advanced imaging or biomarkers, it turns out they really don't have Lewy body dementia. Um, Now that they often have another progressive degenerative disease. Maybe they have an atypical variant of Alzheimer's disease or one of the frontotemporal dementias or Alzheimer's disease and vascular dementia combined, leading to that set of symptoms. And that can be helpful in helping medication choices. So there are with Lewy body dementias, it's the most restrictive in terms of what medications I can use. So with the antipsychotic drugs, with Lewy body dementia, I really only have access to one or two. Whereas if I know that somebody does not have Lewy body dementia, even though their symptoms look that way, I may have more medications to choose from in my armamentarium to try to get some palliation and reduction in the symptoms that people are experiencing. And so every time I see somebody, there's multiple parts to the workup. And the first is defining the syndrome, and the second is coming to a conclusion about a cause or an etiology of that syndrome. And it's not the same for every person, right? So I can do a huge workup in everybody. But some people I may talk to and have the discussion of, well, I think this is Lewy body dementia. It could be one of these others. At the end of the day, I think my treatments will largely look the same. You know, if that person is telling me, look, I don't really care to do all this other workup. I'm comfortable with it's probably this, but it could be one of these other things. If you really don't think it's going to change the course of my illness, then I don't want to do the workup. I'm comfortable with that in some people. And so I don't have the same approach with every person coming in. It always depends a bit on the conversation between myself and patients and caregivers on what we do. Um, Now I'm going to talk about diagnosis and the different types of frontotemporal dementia, and then we'll shift over to treatments. So frontotemporal dementias come in, there's three subtypes, but I'm going to lump them in and I'm going to lump two of them together. So there's the behavioral variant of frontotemporal dementia, and then there's language variants of frontotemporal dementia. The behavioral variant is the one that most people think of when someone says frontotemporal dementia. And this is where people have early and prominent loss of sympathy and empathy, apathy, craving carbs and sweets, ritualistic behaviors, compulsive behaviors, or socially inappropriate. And then the language variants, there are early language changes either in understanding what words mean or in speech and the articulation of words or grammar. And there's less early behavioral changes in the aphasias or the language variants. There's often a lot of frustration there because there tends to be a retained awareness, and it's incredibly frustrating not to be able to communicate what you are feeling or trying to communicate. So now let's talk about treatments in Lewy body dementia. So first and foremost, I treat what's most bothersome if I can. Some symptoms are amenable to treatment, other symptoms are not amenable. And so I spend my time talking with patients about what's bothering them, what's bothering caregivers, what's impacting their quality of life. And then if there are multiple symptoms, and there usually is, we try to focus on what, if we could improve it, what would make life better. And maybe it's hallucinations. Maybe the hallucinations are terrible and preventing people from getting out of the house, and it's causing agitation and or even violence. Maybe it's mobility. And so I never know what I'm going to focus on first because it just depends on that particular patient and what's most bothersome. There is a very nice, it used to be only available on the National Health Service's website in the UK. There is a US based version of this now, and it's a really nice toolkit that the Lewy Body Disease Association has. And so, this is something that you can point, doctors to. This is something that you can give to to folks' primary care doctors. And so there's an overview which kind of has stuff about every symptom set. And so, if you just needed to know one or two things about cognition in Lewy body dementias, you would want to know that it's important to get cognitive stimulation and social interaction, and then cholinesterase inhibitors are absolutely first line. And so this is just the very top line information about approach to cognitive, neuropsychiatric, sleep, autonomic, and motor symptoms. And then there is a management summary for each of those subsets that's multiple pages long. So, for instance, here is the one for cognitive symptoms, and it goes over what a cognitive fluctuation is, how you define it. It goes over some non-pharmacologic approaches and then describes the data that we have for cholinesterase inhibitors, how to start it, how to increase it. So, and it does this for each symptom. And so this is a very nicely available toolkit. Um, so much of what I'm going to say here is reflected in those Diamond Lewy toolkits because I sort of tend to follow the same management approach. For Lewy body dementia, the first, second, and third line is really a cholinesterase inhibitor, acetylcholinesterase inhibitors. This is the mainstay of management. When I've seen large effect sizes in dementia, it's almost always in cholinesterase inhibitors for Lewy body dementias. It's one of the few times that I've managed to fix psychosis and hallucinations is in this scenario. And most people outside of behavioral neurology and dementia specialists won't think of cholinesterase inhibitors as treating hallucinations because they don't, except for in Lewy body dementias. I get to the highest dose tolerated. This is the one time where I go above the sort of maximum dose. So instead of 10 milligrams of Aricept, I will go to 20 milligrams. This is really the only time I do. There's also rivastigmine and galantamine. Rivastigmine is a patch. You can get it in a patch, and that can sometimes avoid the stomach upset that comes along with these medications. The side effects, it can slow heart rate. And so sometimes you do need an EKG first to evaluate for any risk of that. And then stomach upset is the big one. Increased urination, salivation, weight loss is another one that comes up sometimes as well. Memantine has less data behind it. There are ongoing trials, but anecdotally, for some people, it's really a very helpful medication. And so I always do offer and try this in Lewy body dementia. Um, it's usually well tolerated, and so there's very rarely do I have real problems with the drug. Occasionally, it causes agitation. There's case reports of people getting more agitated or having psychosis with the initiation of it, but most people do not have side effects like that from it. If it causes anything, it'll be a stomach upset, sleepiness, or dizziness, usually. neuropsychiatric symptoms. So these are what I spend most of my time managing because these are what I have the most ability to manage, and they are often what is the most debilitating, right? This is what leads people to being to going to long-term care facilities. It's often not the memory loss. It's not forgetting the keys or forgetting appointments or things like that. It's the agitation, it's the aggression, it's the psychosis. These are by far the most distressing and difficult symptoms in my experience. It's important to know that not all behaviors need to be treated. We don't treat a behavior just because it's there. Um, if it's not harmful, if it's infrequent, if it's easily redirected, and it doesn't contribute to distress, it's probably best to acknowledge it and then move on because trying to treat a not harmful or infrequent behavior can lead to more problems. And then it depends on what's causing it. So, for instance, let's say you have a verbal aggression. Well, it depends on what's causing that. Sometimes it's unmet care needs, it's boredom, it's powerlessness, it's being overstimulated, it's impulsivity. If it's an overstimulation thing, there's no good treatment for that other than to remove the overstimulation. Boredom is a really common one. Um, One of the things that I see the most understandable sort of hesitancy about or pushback to is adult day programs. And for some people, they're a nightmare. People don't love them. They it's a bad experience. But just as often, I've had people say, "Oh, they're going to hate it. It's terrible," and then that turns out to be the best thing that they do because it removes the boredom for some people. It removes the lack of stimulation or social engagement, and that may lead to better behaviors. Now, if that aggression is driven by pain or psychosis or depression, then we have a better ability to medicate those things. Um, Sometimes medications are not effective, um, and it depends on the cause. Uh, with the emergence of these symptoms, we got to figure out does it need to be treated promptly? If someone is swinging at people, if they're hitting and hurting people, that is a much more pressing need. If somebody's getting ready to get kicked out of their living situation, that's a much more pressing need. We got to address that immediately, and that affects the medicines that we choose. Um, First, when you want to consider physical causes, and I should say, I'm giving this part of the talk under the Lewy body dementia heading. It's true for this part of it is true for all of the dementias. So this is not specific to Lewy body dementia, but it comes up a lot because there are a lot of neuropsychiatric symptoms in Lewy body dementia. And when I say physical causes, I mean, do they have a urinary tract infection? Do they have some sort of pain or sensory problem? Are they not sleeping well? Were there new medications added? And so with things like with Lewy body dementia, there are intrinsic fluctuations in the illness, and that looks a lot like what happens when people get an infection. And so it's a bit of a balancing act. When somebody's having fluctuations, initially we're often working them up for an infection. And so sometimes there will be concern that there's an infection and we'll work people up. We don't find an infection. And that may just mean there really isn't something, and it is one of these attentional fluctuations as part of the disease. But that's often after we've sought and not found an infection or some cause several times. Medications, absolutely one of the most important things that I review. Um, Benadryl, NyQuil, anything with PM on it is bad news. It's an anticholinergic, causes problems. Benzodiazepines can be a problem. We try to minimize those. There are important caveats to that when we would use them. And then some other common things here: oxybutynine for urinary incontinence, meclizine or antivert for or dimenhydrinate for vertigo. Some antidepressants are a problem. Muscle relaxers can be sedating, and then Dicyclamine or hycosamine for stomach cramps can be can worsen cognition and behavior as well. And so there are often better options out there that we can try to tune things up. Uh, Starting with antidepressants, so where we use antidepressants is not just for depression, right? It's agitation is a big one. They're often first line for milder agitation, and they're first line for depression, and they're first line for anxiety. Part of the reason they're first line is they're so well tolerated. That they cause less harm with using them. And then finally, apathy, but not your SSRIs. The apathy is often better treated with venlafaxine or bupropion, and these are the SNRI class of medications. Um, Antipsychotics. So this is the first place where in Lewy body dementia, there's a real important caveat and distinction. Lewy body dementia is very sensitive to antipsychotics, and that means that by and large, our first line is Seroquel or quetiapine. Pimavanserin or Nuplazid is only covered if it's really Parkinson's disease dementia, because they have to have Parkinson's disease and psychosis to get it covered. Um, there is another medication called Clotharil that is can be a fantastic drug, but it's very difficult to prescribe. Almost no neurologists use it, and it's something that some psychiatrists are comfortable using. I used it in my practice, but it's difficult to use because it can cause problems with blood counts and has to be monitored pretty frequently. We use antipsychotics, not surprisingly, for psychosis, but also aggression and agitation. Um, it's often the case that we don't fix psychosis in dementia with antipsychotics. What we may do is actually reduce the agitation that someone has in the context of their psychosis. So we may not remove the hallucinations, but we may be able to make someone less agitated or angry about the hallucinations. And then if it's real bad anxiety, and we've tried a whole bunch of other things, sometimes that anxiety and agitation can kind of go hand in hand, and antipsychotics can be helpful there. Now, the problem with antipsychotics is there is a black box warning on all of them in all dementias that says these drugs increase the risk of cardiovascular events and death. And they do. There is no question that they do. And it's not just that they're being given to people that are more frail. And so the question is that theoretical increase, is that potential increase in risk worth the potential for the reduction in symptoms? And if the answer is no, then maybe we don't prescribe the drugs. But maybe the answer is we're going to have to deal with some of that agitation being present or that psychosis being present because we have a limited armamentarium. And so I have, in my experience with the more severe forms of agitation and aggressive behavior, I've rarely had people tell me that, they don't want to try that because of the increased risk. But it's very important not to downplay that it's there. It absolutely is there. I would liken it to using fentanyl in cancer pain. Fentanyl has bad side effects, but and it's a big if, it reduces the distress, the discomfort, the pain that someone is experiencing, it may be a reasonable trade-off, but should be weighed in an ongoing fashion. So once I get somebody on a medicine like this, I usually will try to reduce it later and see if they can tolerate less medication later on. We know that many people can. So even if it was bad, we had to treat them with an antipsychotic. 3 months later, if things are going better, we may in fact be able to reduce that medicine. So I use the lowest dose for the shortest amount of time possible. And I would frame it as a palliative option. Cholinesterase inhibitors. So these are Aricept, Exelon, Razidines. So in Lewy body dementia, they can treat psychosis. They're excellent medications there. Avoid these drugs in frontotemporal dementia because they can worsen behaviors in that setting. Um, it can help with depression along with an SSRI in Alzheimer's disease or Lewy body dementia. Um, it can help. It's sort of first line for apathy before we try other drugs to target apathy. Um, Trazodone and mirtazapine are atypical antidepressants, and these are probably both mostly used in the setting of insomnia or circadian rhythm shifts where people just can't get to sleep. Melatonin also useful in more of a circadian rhythm problem where people just can't seem to get to sleep before, midnight, 1 a.m. And is first line in REM sleep behavior disorder for Lewy body dementia. So this is when people are acting out their dreams, running, kicking, punching, screaming, hitting in their sleep. It can be quite bad. People get black eyes. They get, their bed partners get black eyes. People fall out of the bed and break bones. It can be quite violent looking. Um, and so melatonin we use at higher doses. If you all were to go out and get melatonin for yourself, you'd probably take 1 to 3 milligrams. Um, I use 12 to 18 milligrams for REM sleep behavior disorder. So it's a different dose. Namenda, as I said, so the data on Namenda is sort of reduces the global burden of neuropsychiatric symptoms. The data, like I said, the data is weak, but it's there and seems to sort of globally reduce these things and may reduce escalation of an antipsychotic. So I think it's worth trying. Benzodiazepines. So these are on the no-no list, right? You're not supposed to use these drugs. You talk to most doctors. You don't use these drugs in older adults. You certainly don't use them in people with dementia. And it's one of those, yes, you got to know the rules to know when it's okay to not follow the rules. Um, so for bad REM sleep behavior disorder, clonazepam is just unequivocally the most effective drug. And so sometimes this is the difference between people getting an okay night of sleep and not, giving people black eyes and not. And so that can be a very effective drug there. For insomnia, it can be helpful, but I would only use it if it's real bad insomnia, and I would not try to use this long term for insomnia because there's a tolerance that builds up, and you get dose escalation, and it can be problematic. Stimulants. I think a lot of neurologists are uncomfortable with stimulant medications. This is your Ritalin or methylphenidate or modafinil, Provigil. Um, so it can help with depression as an adjunctive, especially when there's sort of a low energy, apathetic depression. It can primarily treat apathy, and there's good data in Alzheimer's disease. And then in Lewy body dementia, there is people with severe daytime somnolence. They can't stay awake during the day, and there's no other identified cause. They either don't have sleep apnea or they have sleep apnea and it's treated with a CPAP. Sometimes stimulants can be a very effective medication for treating those symptoms. Um, Motor symptoms in LBD, it's treated just like Parkinson's disease. If it starts as Parkinson's disease, the motor symptoms are much more severe, and the medicines here are often much higher. In DLB, when it doesn't start with the motor symptoms, often the motor symptoms themselves are less severe. They may not even require treatment. And unfortunately, when they do require treatment, about two-thirds of the time, the symptoms don't respond to Sinemat. So we frequently will try Sinemat, but it's not uncommon that there's no real benefit from it in LBD. Levodopa monotherapy, and that's carbidopa, levodopa, or Sinemat, is the only medicine that I would use there. The other Parkinson's drug, like dopamine agonists, I don't use very often at all because they have an increased risk of psychosis. Um, And with these drugs, even Sinemet, I always warn people that, it's a balancing act. Too much dopamine it leads to psychosis. Not enough dopamine leads to the motor symptoms of Parkinson's disease. So if I give somebody enough dopamine replacement for their motor symptoms, I can provoke hallucinations and the like. So it's always watching for those things. There is there's a couple of papers looking at this anti-seizure medication called Zonegran or zonisamide that has some indication that it may help with motor symptoms in specifically dementia with Lewy bodies as an adjunct to Sinemet. Physical therapy can't discount how important physical therapy can be, especially when people have Parkinsonism. Getting people into a LSVT big program, which is a Parkinson's focused physical therapy, can be very helpful. Autonomic symptoms, as you're seeing, there's just so many symptoms that can arise with Lewy body dementia. There's just a ton of potential need for management and tweaking medications, stopping, starting things, because there's such a wide array of symptoms. So autonomic symptoms can be quite bothersome. Urinary retention, constipation, excessive sweating, all of these can happen and can be a real problem. So with urinary retention, you have to avoid oxybutynin, whereas other things like Myrbetriq are better tolerated. Scheduling urination can help. With sweating, it can be caused by off periods. So when their dopamine drops too low as the Sinemet's wearing off, it can cause worsened sweating. Mostly, though, it's just environmental management and dealing with, finding some way to adapt to or deal with the sweating. In rare instances, people can use Botox in the sweat glands to reduce sweating, but that would be in rare cases. Excessive saliva. People with Lewy body dementia, Parkinson's disease will drool, and they can't. They're producing more saliva than they can handle. So sometimes chewing sugar-free gum can be helpful. And Botox in the saliva can be helpful, and then atropine eye drops in the mouth actually can be helpful. So somebody asked just to repeat the PT group. So the LSVT, so I'm going to type it into the chat here. LSVT big is a Parkinson's disease specific type of physical therapy. It's only going to be real beneficial when somebody has pretty clear Parkinsonism, but it focuses on bigger movements, larger amplitude kind of movements, and can be real helpful there. Sometimes just a gait focused walk, balance focused physical therapy can be helpful for folks if that's what they're dealing with as well. Constipation is a huge problem. Just as we get older in general, constipation can be a problem, but in Parkinson's disease, it's even more of a problem. And in Lewy body dementia and Parkinson's disease, it's a big problem. So avoiding certain medications, watching out for things like opiates, using stool softeners, sometimes mild suppositories, Miralax. You effectively can't overdose on Miralax other than you're going to give yourself diarrhea if you take too much of it. Miralax is part of what they use for a bowel prep when they do a colonoscopy these days. And so, there are your physician can give you sort of a bowel regimen that's common in Parkinson's disease, and that's often Miralax every so often until a bowel movement occurs. Orthostatic hypotension, this is a big one where they stand up and they feel like they're going to pass out. So first line for this is just changing the environment a bit. So stand slowly, raise the head of the bed, increase salt intake. It's the only time a doctor is going to tell you to eat more salt, but that can help prevent your blood pressure from dropping. Increase fluid intake. They've actually done studies where they show if you drink half a liter, so take a 20 milliliter bottle, 20-ounce bottle of water, and you drink that, your blood pressure measurably goes up. And so you'll have people keep a glass of water by the bed. So if they wake up, first thing they do is drink it. Um, there are medications that can help. You got to be careful because then they can get hypertension when they lie flat, and so it can be a complicated balance and requires people learning to check their blood pressure, lying down and standing up to make sure you're not causing that problem. Sleep, sleep apnea should always be evaluated for and treated if people can tolerate it. Sometimes doesn't matter how much you want someone to wear that sleep apnea mask, they're not going to. And you know, at some point, discretion is the better part of valor. If you spend if you spend every night yelling at the person you love to wear the mask and they haven't after 6 months, it's probably time to give up, right? And so that's hard, right? You don't want to hear that sometimes, but that's part of what where my job is to step in and say, you know what, let's just accept we've tried this, it's not working, and it's ruining other parts of relationships and someone's day to day. And so sometimes we just stop trying, and that's okay. It doesn't mean it's not a problem, it doesn't mean it's not contributing, but it might mean that it's time to just accept we're not going to fix that. And the masks are tough, I get it. I wear one, I love my CPAP mask, but I could imagine for somebody who has anxiety and cognitive impairment, boy, it might be a tough thing for them to get accustomed to. um, so daytime somnolence can be part of the disease. It can be due to untreated sleep apnea. Sometimes stimulants are appropriate. I'm comfortable with them. I use them. Not everyone is. They do have the potential to increase blood pressure. There was a study that showed that it increased cardiovascular events in the first 30 days of being on one. But again, like the antipsychotics, it really comes down to what's our goal here? Is the goal to try to mitigate a distressing symptom? And if it is, then we accept the risk and we move forward with that. And if we don't succeed in mitigating that distressing symptom, we stop the medicine. We give it a shot and we back off. Restless legs, another common thing. Always check iron levels. Have the doctor check iron levels, ferritin really. If it's low, they need to have iron replaced. Sometimes antidepressants or antipsychotics can worsen that, so removing those. And then the first line is gabapentin for treating restless legs. Insomnia, sleep hygiene is important. But often hard to get people to do, including myself. So, you want to avoid caffeine in the afternoon. I say, as I have my cup of coffee beside of me, avoid alcohol in the evenings, get a regular sleep pattern, restrict daytime naps, and regularly exercise. Those are all great in theory, and you want to try to implement as many of those as possible. Sometimes just treating nighttime urination can help with sleep. Melatonin, often a good start. A mistake that people make with melatonin is they think it's a hypnotic. It's not like Ambien. Ambien knocks you out. Melatonin doesn't. So you want to take it at least an hour, if not an hour and a half before bedtime. So it's not a drug that you're going to take that just knocks you out. Um, Over-the-counter meds in somebody with Lewy body dementia is almost always a bad idea for sleep because they all have potential problems. It's safer to have one of the prescription medicines. REM sleep behavior disorder, if it's infrequent, doesn't cause a problem, you know what? Bedding on the floor, remove dangerous objects, maybe sleep in separate beds. But that's kind of a lousy answer for people, right? So sometimes melatonin can fix it. And then other times clonazepam is necessary, and it's it doesn't remove the problems of clonazepam, but I think that it can be mitigated. We can accept what those risks are and then try to mitigate, getting up in the middle of the night when people might be a little loopy from the drug by using a bedside urinal, for instance. All right. So moving along to treatments in frontotemporal dementia, and then we will have time for questions and the like. So frontotemporal dementia, this looks a little funny, doesn't it? Hold up. Uh, Hold up. I'm just going to show you this without all the animations because it messed up. Here we go. This is what happens when you try to get too fancy with your slides. So here we've got behavioral variant frontotemporal dementia over here on the left, and we've got non-fluent PPA, one of the language variants, on the right. So these are both frontotemporal dementias, but look at behavior. Behavior is way earlier in the course of this disease than over here. Behavior is a late effect in the language variants. So early behavior problems where you see poor personal regulation, social decorum changes, poor judgment, problem solving, etc. Whereas over here, you don't really see that until much later in the course of the illness. So with treating some of these things, it's again it's the same problems as when we were treating neuropsychiatric symptoms, talking about those with Lewy body dementia. Um, we can sometimes treat things, other things are likely not to get better. And one of the things that I find myself doing sometimes is I might be the first person who's confident in saying what I can't make better. And that is an important thing to hear. And it's because if I don't help set expectations and understanding, how do you know what's reasonable or not, what to expect? And so sometimes just saying this is not a thing that I think I will improve um, can end a quest for that thing to get better, and that in itself can be really important because if you've seen somebody who doesn't feel very confident in it, they may say, well, maybe I'm not sure. Let's send you on to this other person who might be able to treat it. Because I'm kind of the end of the line, there's nowhere else in the state that I can send you for a sort of a more detailed opinion. Sometimes what I provide is more confidence in my answer that can be helpful, if not sometimes frustrating to hear, which I totally recognize. Um, a lot of times with frontotemporal dementia, because these are fundamentally changes in personality, social decorum, behaviors. I mean, these are for folks that are not familiar with frontotemporal dementia, this is not, oh, they're more, they're a little more mouthy than they used to be. This is not, oh, they're just, they said things a little short, right? This is people engaged in behaviors that are fundamentally counter to their pre-illness behavior. So somebody, I mean, I've had patients engage in, trying to solicit prostitutes, and that is not what they would have done before. I've had people, eat food out, pick up food out of a trash can and eat that food. This is a real failure of those social norms in a way that is very different from behaviors in dementia. One of the most common things that I see is referrals where people will say, "Oh, they're young and they have some abnormal behaviors. I think it's frontotemporal dementia." But with frontotemporal dementia, it's a real loss of that rule book of social norms, and the behaviors almost feel different when you're hearing about them, as opposed to patients with Lewy body dementia or some atypical forms of Alzheimer's disease. They're impulsive. They may say things that are hurtful or out of the ordinary, but then when you're talking to them in the clinic, they'll often be able to say, yeah, I shouldn't have said that. That was harmful. That was impulsive. That's different from the person with frontotemporal dementia who's often going, I don't know what to talk. What are you talking about? Why wouldn't I eat that food? It was sitting on the trash can. What's the problem? So there's a real disconnect in sort of the rule book that they seem to be following. Um, in FTD, really nothing reliably has worked with cognition. And really cognition isn't the first thing that's affected for behavioral variant frontotemporal dementia. Cholinesterase inhibitors and memantine just don't work. And cholinesterase inhibitors can actually worsen the behaviors. If we think about cognition a bit more broadly, and the language variants, none of the medicines work, but speech therapy can be helpful. I don't think I have this on another slide, so I'll describe it now. I'll skip it later if it comes up, but non-fluent aphasia is when people have articulation troubles. And there's a beautiful story from a presentation I heard from a colleague who's a speech therapist. A father had non-fluent aphasia, and his daughter was getting married, and he desperately wanted to give a speech at his daughter's wedding. And you can imagine what a daunting task that would be to give a speech when you have a loss of your ability to articulate language. But speech therapy in this case is actually quite effective because you can overlearn a particular set of of sentences, and someone with that disease is better able to articulate it. So they practice over and over and over, and they actually do get to where they can produce those sentences better. And so that can be a very meaningful for that person. Being able to give a speech at his daughter's wedding was maybe the most important thing that anyone could have done for him that year, and so was a real important intervention. It didn't change the course of the disease. It didn't fix anything, but my goodness, what an important thing for him to have been able to do. In FTD, especially behavioral variant, uh, there is more of a deficit in serotonin at the basic science level. And so it turns out that the selective serotonin reuptake inhibitors, which are your typical antidepressants, they have been tried a number of times and seem to improve disinhibition, irritability, and depressive symptoms. Trazodone then is another antidepressant that affects serotonin, can be useful as needed for intermittent agitation and for sleep. Antipsychotics have a risk of Parkinsonism. They're not my first line in frontotemporal dementia. I try the SSRIs and trazodone first, unless I'm in an inpatient setting and someone's dangerous to themselves or others. Then I would go straight to an antipsychotic. When I use them, quetiapine is the lowest risk of Parkinsonism, and so we often start there. Anti-epileptic drugs can be beneficial. Depakote or valproic acid and carbamazepine, or trileptal, can be beneficial. Topiramate or Topamax, there's a study that shows it reduces oral intake. This is a drug that actually we use for weight loss as well. And so it makes sense that people that are particularly hyperoral, eating a lot, craving carbs, topiramate may reduce that. No one has yet published anything on the new GLP-1 inhibitors, your Ozempics and Mounjaro. I'm positive someone is doing that study as we speak to try to reduce intake, because people with frontotemporal dementia and carb craving, I mean, they can gain 80 pounds. I mean, and this is another thing where people will come in and they'll say, well, I think it's FTD. They're craving carbs. What do you mean? They finished a bag of potato chips. Well, okay, me too. That's not really that's not carb craving. Carb craving is I put a padlock on the pantry because they ate 7 boxes of Pop-Tarts, right? Like it's often a matter of degree, as much as anything else. So PT and OT, physical and occupational therapy, can be very helpful, as I mentioned, for the language variants. PT can help decrease falls. Occupational therapy can help with how somebody manages their activities of daily living. Are they safe in their home, etc. And then swallowing evaluations are important across the board for anybody who's having swallow difficulties. And that is what I have on the diagnosis and treatment in Lewy body dementias and frontotemporal dementia. And I'm more than happy to take questions either in the chat, or if folks want to ask them, I will do my best to answer.